Thank you very much, Dr. Lalit Verma, and also many thanks to Jaipur Ophthalmic Society for inviting me. I'll just, my video is very short, uh, but I'll just re-emphasize what Dr. Hasan Mortada pointed out about silicone oil. We had a case where silicone oil migrated to the optic chiasm. Patient had to undergo emergency neurosurgery to decompress the optic chiasm because it was not just affecting the affected this disc pit eye, it was affecting the other eye also with a hemianopia. So that can be very risky in these patients. So always gas in these patients. So I'll be talking about tips and tricks, ILM flaps and grafts. So ILM flaps is about a free flap or an inverted flap, and also I'll be talking about retinal grafts. It's very important to have a very good case selection in these patients. We have published this in ophthalmic surgery, lasers imaging retina. There are cases where you may want to go in straight for an inverted flap, like this large macular hole with retinal detachment. The patient was relatively one-eyed also, and we did in 2015 an inverted flap, got a nice closure. But then there are some cases where, in this case, the hole is not closed after vitrectomy. So the patient already has a macular hole. We did ILM peeling, but it did not close. And these are the cases where you have to take a decision about resurgery and what kind of resurgery do you want to do. There are so many options. I mean, there is no dearth of kind of tissues which you can put inside the macular hole. ILM, capsule, lens capsule, you have amniotic membrane, you have fibrin glue, you have serum, you have blood, TGF beta, all kinds of stuff are available. So it's a question of whether you want to go in or just do a simple additional peeling of the ILM. Just increase the area of ILM peeling and put gas and give the patient a face down position. So these are all the options which you have. And then it's about what outcome do you expect in these patients after the surgery. So why I have stopped here is that if you see this macular hole which has not closed in panel B, is that one of the edges is still lifted, has a lot of edema. And so this patient has a good prognosis for closure. But if you have a patient who has only flat edges all around, then you may probably, just by peeling the ILM and additional gas may not work. You may want to have to really go in for some kind of a flap or some tissue plugging the hole if the whole edge is absolutely flat. But if there is a whole edge is edematous, then you may even consider a simple additional ILM peeling if beyond the arcade and gas. So this is the case. This is a case where you have a flat edge, and you may want to go in for a ILM flap or a free flap and just plug the hole. But there are, it's not easy. You will have to find an area, and also this can dislodge during fluid air exchange. So those can be a problem in these cases of free flap. Then inverted ILM flap is always an option, especially for large macular holes. In India, at least, compared to the West, we see a lot of patients with large macular holes. And this one is close to 1,000 microns. So usually I go in for an inverted flap primary procedure in such large macular holes. I don't really stuff it inside the macular hole. I just do a large ILM and then trim it with a cutter, and then make sure that it gets inverted, do a fluid air exchange, and then give face down position. It's not necessary to stuff the ILM inside the macular hole. Then this is a patient of a retinal graft, which I'm taking the graft, and I've done laser before taking the retina. There are blood vessels which can be near the arcade. I tried to do it under PFCL, but unfortunately with PFCL it didn't go in, so I removed the PFCL. And then the other problem with this retinal graft is sometimes it gets stuck to the forceps. You have to really do it as a bimanual to to try to put, and then it can get displaced too. Even during the fluid air exchange can get displaced. After the surgery, when you give the patient face down position, it can get displaced. So these are the other complications which you can have. So the tip is, I do my best in webinars, but the trick is I avoid ILM free flaps in retinal grafts. So as Dr. Lalit Verma mentioned during the beginning of the webinar, while we may show many things which we do, but ultimately in the patient's interest, whatever is the best interest, we need to do. And also, what are our limitations as surgeons? If in my hand something doesn't work, you don't have to do it just because someone else is doing it. And if you are not comfortable with some procedure, it's best to avoid those kind of procedures. So with that, I'll stop my presentation here.
Dr. Rada, there are two issues here. One is the placement of that tissue, whether it is amniotic membrane, whether it is ILM graft or lens capsule or retinal tissue. So people find difficulty in placement. So people use it under PFCL, people, put visco over it. And second issue is always that air fluid exchange. So can you throw light on these two issues? Dr. Hassan is there?
He was there.
He's muted. Yeah, I think
he is coming.
Okay.
Yeah. So these two issues we thought we'll ask you to comment upon.
Yes. First, if it is a recurrent case, I mean macular hole after previous surgery, this is one entity. And if it is a large myopic macular hole that underwent no previous surgery, for example, a large traumatic macular hole, and if the patient underwent previous surgery, I start again by staining for the ILM. If there is ILM, then I will do an ILM inverted flap, multi-layer inverted flap. And I peel the ILM to the periphery in order to induce more relaxation of the underlying retina. If there is no ILM, and then I would do an autologous free neurosensory retinal flap. But unlike what was shown, I usually fashion a large retinal graft under PFCL. So I inject PFCL, I cut the retina under PFCL, and then I drag the autologous retinal graft under PFCL, because if you try to elevate the graft, then it will be very difficult to immerse it again under the PFCL. So you have to cut it, drag it under PFCL, flushing or tangential with the surface of the retina until it reaches the macular hole, and then it is left over. And then you may exchange the PFCL with air or with silicone oil according to the case. It has to be a little bit larger than the flap shown, because if it is small, it may not stay in place. You should not use visco elastic substance. You should not use helon, because if you use helon to cover the flap, helon will migrate under the flap and over the flap, and then it will be very difficult to manipulate the flap, because you are catching a flap over a slippery surface, and it is also difficult to remove the helon by suction without endangering the flap. So the best is to have a large retinal flap, not less than 1.5 disc diameter, drag it under PFCL until it is placed over the macular hole. Sometimes if it is the patient is highly myopic, there is no healthy retina, I may use amniotic membrane graft, whether it is a preserved amniotic membrane graft or a fresh amniotic membrane graft. But usually I start by multi-layer ILM flap.